Sorry, I'm told we're expecting Stephen. Give him a minute. Okay, right. Good morning, everyone. This is the Integration Joint Board Clinical and Care Governance Committee, which we're holding here today, and I'm Hannah chairing it. So I think without further ado, do we have any apologies?
No apologies submitted to me, Chair.
No apologies then. Any declarations of interest? No declarations of interest. Okay, then we'll move on to minutes of the Clinical and Care Governance Committee held on 17th September. I presume everyone has had a chance to look at that.
No.
Morning, Victoria. Does anyone have any amendments to it? Anything to raise? Or can we accept that as a correct minute? Okay, in the absence of anything, I'll say that's a correct minute then. So we'll move on to the action log. Now, in front of me, there's only one item on the action log. And sorry, and it's closed, so don't think there's anything anybody wants to raise on that, is there? So, moving on then to the first report, the local oversight arrangements. I understand, Sarah, you're going to present that for us.
I am, Chair. Thank you. Good morning to you and good morning to everyone on committee. The purpose of this report is to provide an overview of the local oversight arrangements that are relevant to Falkirk's Health and Social Care Partnership and Committee, and asked to comment on the contents of this report. At its most recent meeting, Falkirk Public Protection Chief Officers Group considered an adult protection learning review, and the COG, as it's known, agreed to endorse the findings of the learning review and to endorse the approach for internal and external learning as recommended by the Adult Protection Committee. Chief officers were also presented with the Missing Persons Protocol, and following a thorough independent multi-agency review of the policies and procedures in place across Forth Valley to support a response to children and adults going missing, 18 recommendations have been progressed by a short life working group, which was led by Police Scotland. The thematic pieces of work that were progressed as a consequence of that work are outlined for you at 4.6 of the report. One of these is the Philomena Protocol, and that was launched force-wide on the in May of 2023 to coincide with International Missing Children's Day, and it's now widely used across the country. One of the key themes and objectives of the Short Life Working Group was to reduce the missing episodes of children who are care experienced and to reduce the risk of them, of the amount of episodes, as well as the important aspect of improving relationships across the partnership within this particular set of issues. It's of note for committee that following the work of the Short Life Working Group, there was a review carried out of missing cases, and we found a 37% reduction in those cases over an 11-month period. So as it was a Short Life Working Group, it came to an end after 11 months of the development work, and all of the outstanding actions that we grouped together at the end of that process have been delegated to appropriate groups. They're all being progressed on a Forth Valley basis, and there's suitable oversight by related committees. Chief officers also considered feedback from our very first COG leadership event, which we titled Public Protection Across the Lifespan, bringing very much together our child protection and our adult protection lens. And that was in September by webinar. 156 people joined, but we did video it and we're using that link to be able to ensure it's got wider reach. Feedback was really positive, and we also asked for ideas from our audience about what they might like as a future topic, and gender-based violence was the one that we found had the most requests. Section 5 of the report provides an assurance overview from our alcohol and drug partnership, and our newly formed EDP exec continues to meet quarterly, and we've got those dates now aligned with IGB meetings, and that's all about ensuring our decisions can be ratified really swiftly by the IGB. Of note is that the ADP are currently working with partners to review the drug-related death review process, and the new overdose monitoring and drug-related death review subgroup aims to meet for the very first time in January of next year. 5.6 of the report notes that the ADP is developing an alcohol harms subgroup to focus work in this area. So we talk a lot about the drug aspect of the ADP, but we still retain a strong focus around alcohol harms. An initial strategy has been developed for the remit of the work, featuring key outcomes and specific areas of focus. There's been meetings held with a variety of key stakeholders, and they've all expressed a really strong interest in contributing to the work, which is really positive. Importantly, for us and the work that we do, the ADP Lived Experience Panel has met several times. They've branded themselves with the name Authentic Voices Group. They will continue to contribute to the development of our locality plans, MAT standards data collection, and we are supporting that group in the same way that we are receiving really amazing support from them. Recently, the ADP supported walkthroughs as part of MAT Standard 10, and that is about services being trauma-informed. There is a final report which will be presented soon, and then those services will be responsible for developing an action plan. ADP is just about to undertake a full strategic needs assessment. We've been working towards this point. We're pleased to be at the start of this. It will take around 6 months, and it will importantly provide a foundation for us to develop a new 3-year strategy and delivery plan. Lastly, at section 6, Adult Protection Committee, really just to highlight to committee that we have a new Adult Support and Protection Quality Indicator framework, known as the QIF. It's been published by the Care Inspectorate recently this year. It's been developed in partnership with the Adult Support and Protection National Implementation Self-Evaluation Subgroup. This is important for us. It's the tool that the Joint Inspection Team will use for future inspection activity, and for us as Adult Protection Partnerships to carry out multi-agency self-evaluation. So 6.4 outlines its intentions. That's the Care Inspectorate's intentions with the new tool. We are planning to firstly benchmark ourselves using the new framework, and then continue to build and improve from this position. And reports will be presented to our Adult Protection Committee as we progress with this, and onward to the Integration Joint Board and to this committee as required. Thank you, Chair. I'll stop there.
Okay, thank you very much. Does anyone have any questions or comments they want to make? Not seeing any hands. I wonder if you could say just a little more about the Philomena protocol, just to explain how that works, what it is.
So the Philomena protocol is a toolkit, and it includes a number of different elements which support the police specifically to be able to swiftly work together with partners to locate a missing person. It's very much a person-centred tool So although it comes with words such as toolkits and database, it is a form which is a friendly form that can be used with people. It shouldn't be something that sits in a file and has not been informed in any way by the individual that it is relevant to. So it is about engaging young people in the assessment around the risks of them being missing. It engages them in a way that we can support them to best locate them swiftly, and allows us to, when we have young people returned and they're meeting with the person that has been identified by them as the individual who they feel relates best to them, they can have a conversation around the information that's been provided within that particular form, to ensure that we need really to be in a position where young people are giving us a really strong sense of the reasons why they're choosing to go missing. We want to be informed through that form about where we might best go to locate them. So essentially, it's a set of different tools under one banner that is used prior to a person going missing, and is also used as a follow-up once the person has been located from that particular episode.
Thank you very much. Very clear. Thank you. Tom?
Yeah, thank you very much, Chair. I wonder, at a risk of opening up a bit of a hornet's nest here, I wondered about the ADP's lived experience panel renaming itself the Authentic Voices Group. And I wondered what the intent was there, because in some respects it might somewhat imply that those who sit outside of that, in other words, all of the professionals and everybody else, are somehow not authentic. And is it the sense that that group feels that those sitting outside that group are not authentic? I thought the lived experience panel is actually a good name in terms of reflecting what they are. But I just wondered if there was anything specific behind that decision.
And can you enlighten us, Sarah?
I think Phil might be here, who might be connected to that decision, but Tom, my understanding is that it was their choice.
I dare say. I'm just trying to understand what the thinking was there.
I wouldn't be able to answer for them. I think that question probably goes back to them, Chair, and that we could show the interest from this committee on the back of the question that Tom has raised, because it's an interesting point for us to open up a conversation with them about. But yeah, my understanding is that it's their panel, it was their decision to create a name for themselves. That was the name that they chose, and certainly we can go back to, but it's not a question I feel as though I'm qualified to answer.
Yeah, Chair. Again, Chair, if I may, in no sense am I trying to criticise the group. I think sometimes, however, when a range of different people are having to try and deal with a very, very challenging issue, and they are in some respects on the inside of the challenging issue, and the general public and everybody else are on the outside of that, sometimes these things can indicate and label themselves in such a way that kind of implies that there is those who really know what they're talking about and those who don't, and that's not necessarily terribly helpful. I imagine it's completely unintentional, and in fact I can get what's behind it. They feel that they have something important to say, and they're absolutely right. But I just wondered about that. Sorry, I'll stop.
That's fine. In Phil's absence, he was here earlier on, but seems to have dropped out of the meeting. So perhaps Sarah could ask Phil to pick that one up and come back with some kind of an answer. Victoria, unless you have an answer.
Yeah, thank you, Chair. Excuse me, I'm loaded with the cold, so forgive my voice today. For us, we work with a number of lived experience groups, and their feedback is that they really don't like that label. And so we are seeking to change the titles of a number of groups that we work with to give them that level of dignity. They are authentic in the way in which they speak because they know the topic inside out. But you're highlighting it to everyone and anyone that you have had that lived experience, whether that is through drug and alcohol addiction, whether it's through poverty, whether it's through abuse, whether it's through mental health and wellbeing, whether it's young person's trauma. So I can't speak on behalf of Phil, but that's certainly the avenue that we are going down with our own lived experience groups and panels, just to try and explain perhaps some of the rationale behind it.
I see Phil has rejoined us. So just for your benefit, Phil, Tom was asking a bit about why the Lived Experience panel has renamed themselves the Authentic Voices Group. And we wondered if you could elucidate with the Tom's question being, does that suggest that others are not an authentic voice, that others involved in this? I'm not sure if Phil's hearing me.
Yeah, I'm hearing you. Yeah, it's a really good point. I think Victoria, from what I heard, pretty much covered the thinking behind why they're called Authentic Voices. It's a name that they decided on themselves. There was a lot of various different suggestions made, experts by experience. I think that the lived experience element of the ADP work, and indeed all work that's going on in Health and Social Care Partnership, is really key. There's been a real shift over the last few years to include people who have been through the system, who are experiencing these issues themselves, to contribute to the design of that system as well. And I think part of this is to elevate their place within this, rather than just calling it a service user forum, which has baggage of different meanings for different people. It's about placing that group and their comments and their opinions and their experiences right at the centre and the heart of what we do in the ADP. Again, I'm not going to say much more, because from what I heard from Victoria, she pretty much covered it in terms of why we call them authentic voices. It's by no means intended to allude that the professional aspect and their approach is any less relevant. It's to highlight that theirs is something a little bit different, but no less important. So. Yeah, happy to take the conversation off table, or invite anybody who wants to come along to the Lived Experience panel to experience it themselves, experience the meeting. You'll be more than welcome to come along and talk about the work that you're doing, as well as the work that they're doing as well. Thanks, Chair.
Okay, thank you very much. I think that's a fairly full and detailed response you've had, Tom, and an invite. So there we go. Just while we're on the ADP issues, I just wanted to pleased to see that on the subject of another name change, pleased to see the drug-related death review has been called now overdose monitoring and drug-related death. I think I've raised before my issues about the importance of actually looking at those that don't die and trying to learn from that experience. So congratulations on that one, that name change. The other thing I just wanted to highlight was at 410, going back to the missing persons issues. I think it's worth emphasising that 37% reduction in missing cases over an 11-month period is quite a significant figure. So congratulations to all involved, assuming that that's because of the work that's been done rather than just chance. So I think that needs to be highlighted. Any other questions or comments? In that case, I think we have considered and commented on the contents of the report. Can agree with that. And we move on now to the Clinical and Care Governance Management Group update. And I think that will be Nicola.
Yeah, thank you. So the purpose of this report is to provide committee with an update from the Clinical and Care Governance Management Group. And committee are asked today to consider and comment on the update provided. So the Clinical and Care Governance Management Group is to receive reports from core subgroups as described in section 1.2. We've also recognised that there's a significant overlap between the health and safety management group and the clinical and care governance management groups. So in order to reduce duplication moving forward, the health and safety group will also report formally to the clinical and care governance management group. Given we've now had a couple of cycles with the new model, we are now working to update the terms of reference and the care governance framework. These will be updated in the coming weeks and we'll go through various approval processes in the coming weeks. Section 2 of the report highlights the range of areas considered by the management group, and I won't go through them all, but I thought I would roll out some of the highlights of the report. So compliance with safe staffing legislation. So all areas have articulated compliance with requirements and they've all reported clear escalation processes if there were any staffing concerns that would have the potential to impact on care delivery or safety. The interim head of integration is currently finalising recording the reporting templates for social care services. And at the last management group, it was also noted that there was a decrease in sickness levels across the internal problem settings, which is positive to note. Health teams across the partnership area have real-time staffing assessment templates in place. And that basically means that once per day, at least once per day, each service assess their staffing levels across all of the areas, and any risks escalated in a timely manner to the appropriate manager. Any mitigations that are required to put in place, and they are also recorded in line with the legislation. Any results from unannounced care assurance visits in the last reporting period across the partnership areas were discussed, and assurance was provided in relation to improvement plans that are ongoing as a result from them. Assurance was also provided that improvement plans from previous care inspectorate visits or mental welfare commission visits are being progressed and monitored appropriately. It's also been highlighted through this process that the care inspectorate visits to the internal care homes remain outstanding, and they're expected to visit our services, so we'll make those visits. Any safeguard reports and care inspectorate notifications were also reported from all areas, and the management group considered any emerging themes, trends, areas for improvement. But the management group did obtain assurance that there was no unusual trends highlighted from these incidents. So as described in section 3.6 of the report, there's also been the creation of a new Handful Valley Community Adverse Event Review Group, and this group allows for adverse events to be submitted and to be reviewed by senior clinical leaders. The senior clinical leaders in this group then, following consideration, can then escalate further to the shared intelligence group, which is chaired by the medical director and the executive nurse director. And that the shared intelligence group can give further consideration of any other requirements related to the adverse events that may be required, and that is up to and including the commissioning of significant adverse event review if indicated. So this development of this group now provides services with a standardised process of escalation for events, and it further strengthens the governance and safety across. Discussions were also held in relation to the importance of effective communication during transitions of care, particularly upon discharge from hospital. And as chair of the management group, have personally liaised with colleagues from Forth Valley Royal Hospital, and work is underway to improve the timely completion of discharge letters. And we will remain connected with our colleagues in Forth Valley Royal Hospital around that, and hopefully start to see some improvements in that area. An update's been provided in section 4 of the report in relation to the Partnership Health and Safety Management Group, and 4.2 highlights the areas discussed in the most recent meeting on the 30th of October. And as described in the paper, future steps to include the Health and Safety Group formally reporting into the clinical and care governance structure moving forward. As mentioned, we'll also review the framework in terms of reference to reflect the revised structure, and we'll also ensure that there's ongoing review of the membership agreement of the groups. One final thing for future steps is we have asked for data over time to be submitted from all of the subgroups to allow us to discuss not just single points in time data, but actually how it compares to previous periods. And we've now got agreement that the Partnership Improvement Advisor will support the workstream leads around this and how to gather the appropriate data and how to present that in a meaningful way that we're able to interrogate it and have some meaningful discussions. So I think I'll stop there, but I'm happy to try and answer any questions that you have this morning.
Thank you very much, Nicola. Does anyone have any questions or comments they want to make?
Of some really, as come up before about this issue of discharge from hospitals, really happy that is looking at this issue, and one of the things that we've focused on previously has been letters from the hospital to the GP practice, but also we need letters or communication from the hospital when somebody's been discharged to the home care service, because so often people have been discharged and social worker are totally unaware that they're discharged and there hasn't been a package of care that restarted. So is that part of that as well?
It's absolutely part of that, all transitions of care from, and it includes actually going into hospital too, because we need communication to work both ways, but it's absolutely included in both ways.
I think that's welcome, because that is one of the areas where we have seen in the past some issues arising, and the smooth transition makes everyone's life much easier. Any other questions or comments? Please have a say thank you very much, Nicola, and we'll move. Oh, sorry, no. I do need to get your agreement that we have considered and commented. Okay, thank you. Now moving on to the Health and Social Care Partnership Complaints and Feedback Performance Report. I think that starts with you, Gordon.
Good morning, Chair. Yes, thank you very much. The report, I'm going to go to the appendix to the report for the detail of this, page 33 and thereafter. As you can see from the report, there has been continued improvement in terms of the timescales for dealing with complaints at stage 1. Last couple of quarters, this quarter and the previous quarter, saw a bounce back from Q4 last year. So that's a positive, and we're obviously keen to keep that going. Particularly in context of a significant increase in the number of complaints. That's another issue. We see in Q1 and Q2 of 24-25, complaints are probably almost double what they were in Q3 and Q4 of 23-24. So I think that's a bit of a trend, and for the next report, I'm going to do a bit more of a deep dive into that. I did have a look at the figures when they came in, and there isn't clearly identifiable one area where we're seeing a sudden increase in complaints. It's fairly widespread across the board. So I'll need to go into that and see what else there is that we can learn from those figures and for the data generally. Looking at the numbers, they're on course to be slightly above what they were at pre-pandemic levels. So we might be returning to pre-pandemic levels of complaints, or it might be something else. So I'll have a look into that in more detail for the next meeting. Other issues to highlight. There was a dip, obviously, in stage 2. The response times to that, the numbers there are quite low. So just need to keep an eye on that, make sure that it doesn't dip any further, and see if there's any particular reason for that. Again, the numbers in stage 2 complaints are up a bit on previous years, so be looking at that as part of the deeper dive. On the positive side of things, we're continuing to get a number of positive feedback comments through the Council's reporting service, particularly the Joint Equipment Service. Seems to be getting good comments on a regular basis. possibly a cultural thing, but I'll continue to reinforce the message that if there is positive comment coming to other teams, then we want to know about it, we want to share it and celebrate that as well, because it is definitely a boost for staff to hear that people are commenting positively on the service. So happy to take any comments or questions at this point, or to hand over to Ailey for the NHS element, whichever you prefer, Chair. Thank you.
Take questions and comments first and then go over to Ian afterwards. Yeah, that's all right. Any comments, questions? I mean, I'm glad to hear that there's going to be a deep dive into the numbers. I was going to ask about that, because sometimes it can be just that more people are willing to make complaints, or it could be that there's been more reason for complaint. We need to know which it is. Yeah, so I'm glad you're going to be looking into that in some detail, and also glad to hear of positive comments too. We can learn from positive comments as much as we can learn from the negative ones, which is important. Anyone else want to ask questions, make comments? If not, shall we move on? Who's taking this one? Sorry? Ailey.
Good morning, everybody.
Sorry,
Thank
I
you.
apologise.
No, don't worry, Chair. Thank you very much. Apologies for my voice as well, everybody. It's a bit hoarse this morning too. So on behalf of the NHS side of complaints, there have been 15 complaints within the reporting period. Performance is currently a combined 40%. Stage 1 performance is 42.9% and stage 2 is 0. There are, and I know I've spoken about it in this forum before, across the entire organisation, there are absolutely demanding capacity concerns at the minute. That's something that we're addressing with the governance forums corporately on NHS's side, and we're looking to see how we can look at staffing to support that, and also look and see if there's any other more creative solutions that we can come up with. But at this moment in time, we do not have the capacity within the department to deal with the demand, which is part of the picture probably in terms of that 0% performance rate. We do have difficulties in capturing all the information that we need to allow us to respond on time, and again, that's something that we're working with local units. The number of complaints received in September was 7, which is the highest volume per month year to date. There were a few similar months in the 23-24 reporting period, but largely actually we sit between 2 and 5 each month, which is in keeping with last year. So we think September's just probably been a single data point of variance, but we'll certainly keep an eye on it. The main concerns raised relate to treatment coordination, aftercare and communication, although very few complaints are actually upheld. There were 2 complaints collectively that were either partially or fully upheld within the reporting period. The one that was upheld related to individual staff conduct, and we believe very firmly was human error. And the one that was partially upheld actually related to waiting times for diagnosis as a result of the complexity of diagnosis. Sorry. As Gordon said, similarly, we do see feedback from our different care opinion and compliance mechanisms. That's all contained within page 3 of the report as well, and we certainly strive to make sure that the different teams get that feedback back so that we can reflect on that locally as well. And we are looking internally at our excellence reporting, which is how we do peer-to-peer reporting of generally good work, good teamwork, and where things have gone well. So it may be that we change some of our approaches to that, or at least re-advertise it. So hopefully we'll be able to celebrate next time we meet what our staff are saying about each other as well.
Thank you very much. You made mention about a capacity issue. I wonder if you'd like to say a wee bit more about what's happening there to resolve that.
Absolutely, Chair. So it's a long-standing problem. The volume of complaints received across the organisation went up by about 26% over the last year, particularly triggering sort of November time last year. We've been monitoring that, but that has been sustained. We've got some interim measures in just now in terms of additional staffing. However, that volume has been sustained, which means we need to look at more sustainable solutions to the staffing footprint. We've been through most of our processes now and we are recalibrating those. There are short life working groups that meet on a monthly basis about the impact of those and making sure that we've not got any unintended consequences anywhere that we're missing, making sure that that is all working well. So we're tackling that to the best of our ability at the minute. It's on our corporate risk register, so we are recognising across organisational level right now that we aren't where we need to be in terms of the capacity to deal with the demand. So we've approved 2 new vacancies within the last month, both of which have hopefully now been appointed to, pending people accepting and need to go through that recruitment process that will help us longer term. But I do still think even after that, there's going to be a bit of a sort of, there's still going to be some excess demand that we can't meet, but that will go to Sprig and we'll see what the outcome is from that.
Okay, thank you very much. Does anyone else have any questions or comments? Roger?
So just a question on page to the back on 3.1. It says, or where consent was not received. Can you just say what circumstances somebody makes a complaint but doesn't give consent?
So that'll be where a relative or somebody's complained on someone else's behalf, and we would then write back to them to say, do you consent to us continuing with this complaint, and do you consent with us dealing with the other adult as your responsible adult ultimately on the complaint, or your next of kin, etc. So if we don't receive consent from that, we are unable to proceed with the complaint about individual patient care related aspects. What we may be able to do though is deal with some of the aspects as more of a concern if it's about general waiting times or a contingency bed approach, some things like that. We can take some of that as general concerns, but if we don't receive consent, we can't proceed to investigate the individual care provision.
So does that mean if somebody has dementia and a relative complains on their behalf, that complaint can't be investigated in the same way?
So no, because dependent upon capacity, but if the individual's got capacity, then by default we wouldn't have the authority to go and dig through their case records, etc., to fully investigate that. So it is complicated. We do keep them documented, but we just don't formally report on them at the other side, because we've not been able to come up with an outcome or a finding of an investigation because we don't have the consent to do so.
Well, it just leaves me a bit concerned that people who are some of the most vulnerable people that we deal with won't have their complaint looked at in the same way, as less vulnerable people who are able to make that consent.
So, but if there wasn't capacity to make the consent, we wouldn't ask for that though. So it's only if you've got the capacity to consent to a complaint investigation. It would fall under the same sort of auspices of a power of attorney, etc., for anything else, and that would still be investigated.
So people without capacity will still.
Yeah, absolutely.
Just in the same way, just as thoroughly as somebody with capacity. Thanks.
Yeah, absolutely.
Okay, any other questions or comments? In that case, I think we can assume that we have considered and commented on the report. So we move on now to item 8, the final item on the list, the Healthcare Acquired Infection Performance Report. And this is Jonathan.
Morning, Chair, and morning, everyone. So yes, this is the quarterly report for July to September. Just quick talk about the AOP targets, those are board targets. We're still yet to be any targets to be set. If you probably remember that the last targets expired in March of this year. So we are anticipating some interim targets to be set with the proviso that full targets are going to be set come March 2026. So still that's out for debate at the moment, what type of targets they're going to be. We anticipate they're going to be very similar to what we're currently reporting on, but we're anticipating we'll hear some interim targets earlier next year. Moving on to care home support continues. Our main focus is continuing with our scheduled audits and our proactive training that we do with the care homes. We are finding a great positive impact to the care homes and the staff, and also feedback from the staff about the training that we're actually providing. We've now develop relationships within the care homes, that they're actually reaching out to us and saying, we've got new staff, can you do some training for us and things. So this has been quite successful. So overall, there's no concerns to raise in regard to what we've seen in the care homes for this quarter. For surveillance, for our Staph aureus bacteremias, the device-associated bacteremias, E. coli bacteremias, and our C. difficile infections, we have seen an increase this quarter, predominantly within the healthcare setting. So this is where they've had some form of healthcare interventions, but out with the hospital, and also we've had increases in our hospital infections as well. Fortunately, numbers appears to have settled or settling this quarter. So I'm hoping the next report I'll present will give a more favourable report there. However, having said that, there were no reported infections attributed to Bowness or Falkirk Community Hospitals for this period. For our state and cleaning compliance scores, I'd just like to highlight our Falkirk Community Hospital for our state scores is now sitting in green, and with the compliance score of 90% for several years now. This has been sitting in the high 80s in terms of scoring for the last several years. So this is quite something to be very pleased about, that this is now in the green. And finally, just like to highlight about outbreaks. There were no reported outbreaks for Falkirk or Bowness Community Hospitals for this period. Just like to give the committee assurances that we are closely monitoring COVID, RSV and flu levels currently across the country, and also within our board. And so we anticipate, as usual for this period of time, increases to start. We're seeing increases probably towards the back end of December, certainly with influenza, that we do see historically we've always seen increases in that during the latter part of December. So just give some assurances that we are prepared for this, and we're continually monitoring this as well. So happy to take any questions.
Jonathan, does anyone have questions or comments? Margot.
Just a quick question, Jonathan, about the I think you have an infection control group.
Yes.
That's looking at issues like not overcrowding, but having 5 beds in a 4-bedded unit, etc. Is that correct? And what are its findings, really?
Right. So there's a great deal of effort now to stop that. We did that through the COVID, through the pandemic, and just at the back end of the pandemic, where we had to increase capacity at the ward level. That has now, every effort has been stopped. I don't believe, I don't know how the data on me to give accurate data, but I do believe that there's no patients within a fifth patient in 4-bedded areas. We do use other rooms that are identified within the wards that are used in extremis, but there's every effort at the moment that it's not common practice at the moment, Margot, not anymore. So I hope that gives you some assurances.
Thank you.
So Jonathan, you referred to an increase in this quarter, and a significant increase in this quarter, but that it's levelled off.
Yes.
Leveled off. Do we have any idea of causation, or?
It's been quite a busy quarter. We've had quite high levels of acuity within the hospital, and we've had and associated infections as a result of that. In terms of any areas of commonality, we didn't identify any areas that the numbers were just higher overall. There weren't any clusters of a particular type of infection or a particular source of infection, should we say, that we could concentrate on that would identify the reasons for this. We had quite a number of patients coming in with biliary sepsis, so people who've got gallstones and have subsequent infections as a result of that and things like that. We have quite a number of them, and that continues to be a bit of a problem for Forth Valley, but there's not a great deal of interventions that from an infection prevention control point of view that we can actually influence there. You know, there is work that I'm doing, some research that I'm doing in terms of biliary sepsis, and I'm hoping to present that to our surgical teams, and I'm going to be approaching the GP subcommittee as well in due course as well, just to sort of identify sources. There is actually part of the Patient Safety Collaborative, which is a Forth Valley-wide collaborative. We are looking at urinary catheters, and not so much looking at infections, because it's not easy to retrospectively look at infections associated with catheters, except in events of sepsis, which I report on. But there is an effort to look at catheter prevalence across Forth Valley, including care homes and in primary care, and to see what we can do to sort of reduce the number of people with catheters in, and whether or not, and to review those patients, see whether or not they actually need a catheter in the first place. So we're hoping that those little steps would help. If we reduce the number of urinary catheters in patients across Forth Valley, then we'll have subsequently less infections as well. So there is some work, that we can do. There are other aspects of infections that would fall under my remit with regards to sepsis and urinary, complex urinary tract infections that turn into sepsis events. But again, those are very tricky ones to actually influence in terms of from a infection prevention control aspect, unfortunately.
Thank you, Jonathan. That reassuring that the work is being done sounds most interesting. I think it's worth congratulating the Falkirk Community Hospital on having at last exceeded the 90% success rate. That's to be given all credit due to them. It's been a long time coming. Any other questions or comments? Margot, yes.
Very quickly, the number of people with care packages who are in their own homes, and really primary care, I think, looks at these issues, but a number are apparently sort of catheterized, and I don't know if that's causing any increase. Is that reported to you if there are infections with people who are in their own home being?
Yes, I mean, certainly the ones that we follow, that it's when the infection expand. It's not just a local infection. It's not just a local urinary tract infection associated with the catheter. We look at those who have developed into sepsis and require admission. So we are urinary catheters out in the community is quite a difficult one to address in terms of the management of the catheter. Quite often the district nurses provide inputs to them, during catheter change, or if there are any challenges like blockages, or if the urinary catheter has slipped or something. But other than that, there could be a period of weeks where the responsibility to look after that catheter lies with the patient as well. So apart with the safety collaborative that's ongoing, I think it might well identify that we need to provide more robust information to patients going forward about how to look after their urinary catheter. I think that's probably one of the outcomes of that group, but I can't predict what all the outcomes are going to be, but I suspect that'd be one of them.
Thank you.
Okay, thank you, Jonathan. Thank you, Margot. If there are no other questions or comments, can we say that we have considered and commented on the report? And once again, thank you to all for your input and for your hard work. And thank you for coming this morning. And we'll say goodbye.